All right, so welcome back to Ultrasound Grand Rounds again this week. Pretty excited to be here with you today. As always, today is the changing of the seasons. It's cooling off. The weather is kind of weird today. It's alternating between sunny and kind of rainy and cloudy. I was driving through the valley here in Cleveland earlier today and just looking at the hillside, and all the leaves are in full bloom. And so it's really a beautiful time to be here, not only in Cleveland, but just be doing ultrasound today. So we're going to dive into today's topic. We're going to talk, we just transitioned away from some cardiac ultrasound, and we're going to do a little bit of a lecture here today about Doppler ultrasound and how to use that at the bedside and some of the basic principles of Doppler ultrasound. And there's a special announcement that you're going to want to listen up for, and we're going to do that at the end of the lecture, so we'll see you then. But for now, let's transition on over and talk about some Doppler ultrasound. All right, so today's topic is Doppler ultrasound made easy. And yes, it's a little bit of a clickbaity topic or clickbaity title, but the whole point of this is to really get us into this notion of doing Doppler ultrasound and kind of demystify, simplify it a little bit. We can go as deep and complex as we want, or, the clinicians in us are like, we don't need all the deep theory and all the details. As long as we understand the basics and then learn how to apply that, then we can use that application throughout our different scanning at the bedside and in the emergency department or critical care environment. So that's what we're going to talk about today, Doppler made easy, as we kind of move through this here. So we're going to do this in a couple different broad categories. The first one is I want to talk a little bit about Doppler physics, right? We have to start all these discussions with an understanding of how things work and why they work before we understand how we can manipulate them to make them work to our choosing and to our liking. So let's back up. Let's talk a little bit about some physics, and then we'll kind of build on that to understand some more of the principles of Doppler ultrasound. So remember, the basic idea of ultrasound is it's reflected waves of sound, right? So the machine sends sound waves into the body. Those sound waves are influenced by the tissues that it goes through, right? It's either attenuated, it's reflected, various different things, and it returns back. There's the echo that comes back, and that echo is then picked up by the machine and it's displayed, right? And we'll show some images in that in just a sec. But if we remember, it all comes down to this equation that the frequency that's being transmitted times the wavelength equals the speed of sound in that tissue. So we know that the average speed of sound in most soft tissues is 1540 meters per second. It's going to be slightly variable, whether it's a liver or kidney or fat tissue or skin tissue or whatever, right? But it's all going to center around that 1540 meters per second. And so if we use that as our number, then we can take the frequency that we're transmitting, that's going to translate into a wavelength, that sine wave, that sound wave that acts like this sine wave that I see depicted here is going to behave, right? And so when we understand this, we're going to come back to this basic model of this wave, this sine wave, this wavelength as kind of this fundamental principle. And so just for further clarification, one frequency, right, 1 hertz is 1 cycle per second. So going from the very far left on this screen, right, where it starts at the baseline and goes all the way up, goes all the way down and comes back to the baseline. So it's going to cross the baseline twice, right, is 1 cycle. It goes up, down, back up, 1 cycle. And when we're talking about ultrasound, we're talking about things in the megahertz. So it's 1 plus a lot of zeros in terms of how fast that happens in a particular second. But we can break it down to this sine wave of it goes through 1 cycle per second. Now, this is the fundamental assumption of all ultrasound, right? I'm going to blast this out at X many hertz, right, or X many megahertz. And so you get to a piano, you hit, one of the, the keys, right? It's going to be a frequency that's transmitted at a certain number of hertz, right? And we hear that. And so one of the main assumptions with ultrasound is what gets sent out is what gets sent back, right? So if I send something at, let's say 2 megahertz, I'm going to hear it back at 2 megahertz. But the reality is we don't always get our signal back at 2 megahertz on the nose, right? It may be something slightly different. And so when we see this, right, we see this slight difference in variation in the frequency that's returned. This is where we get the basis and the fundamentals for Doppler ultrasound, right? We're going to measure that delta and we're going to look at that. And this is all based off of the work of a guy named Christian Doppler. So he lived a long, long time ago. And he noticed when he was looking at stars that some of them looked red and some of them looked blue, right? And he made this postulate that basically the frequency that you observe is affected by the movement of that thing. So this isn't a direct quote from him. This is just kind of a summarization of kind of what his work would be. But it's the frequency of a wave, we just showed that wave, right, is dependent on the relative speed of the source and the observer, right? So the ultrasound probe, just applying this to us, the ultrasound probe is going to send out a sound wave at a certain frequency, right? We receive it back at a measured frequency, right? If that thing it's interacting with in the process of its transiting through the body is moving, that movement may also have an effect on the ultrasound, the frequency of the wave that's coming back on the ultrasound. And I want to prove this to you with an example here. And you're gonna have to listen carefully because I don't have this piping through my computer to the live thing. We'll get it better for the YouTube video. But I have a video of a train here. So my oldest son, we're on the topic of family today, right? My oldest son, since he was young, really loved trains, right? And so we have visited so many train museums, watched so many trains go by. It's not even funny, right? And my other poor kids, we need to find and develop interests that they have. But my oldest, being the firstborn, a lot of his interests get kind of extrapolated out to the rest of the family. But that being said, there is a train that comes to Cleveland. I think it's still on an annual basis. It's the Nickel Plate Road 765. It's based out of Indiana, and it's a steam engine that has been obviously restored and continues to run, and it comes every year for the Steam in the Valley. It's a big event and it's a lot of fun. So we went and watched the Steam in the Valley, and when we were standing there, you can hear the Doppler principle in practice as the train whistle is going, as the train is coming up to us, approaching us, and then going past us. So let me play it, and then we'll talk a little bit about it. So it's subtle in there. Hopefully you guys heard it. As the train was approaching us, right? This is the Nickel Plate Road 765 that we love to go watch with my son, right? As it's approaching us, the pitch of that horn or that whistle is a lot higher, right? And as it passes us, as it goes immediately in front of us, you can hear the pitch of that whistle drop. Subtle, but you can hear it drop. And this is the Doppler principle in effect, that as things are moving towards you, it compresses that frequency. And as things move away from you, it will expand or decompress that frequency. So it'll be slightly lower frequency as it goes away from you, slightly higher frequency as it goes towards you. And we use this principle in ultrasound to then detect the relative direction and velocity of movement. And when we talk about movement, we're talking usually about things that are vascular in nature, right? And so when we have blood that's flowing away from the transducer, or blood that's flowing toward the transducer, that movement is going to cause a compression or a decompression of that frequency. So the return frequency will be slightly higher or slightly lower. And then the machine can detect that difference. It says, hey, I sent it out at this frequency. I'm receiving it back at some other frequency. There's a delta there, and I'm going to display that delta in some capacity. Depends on what format we have it displayed in. But in this context, we're going to display that as a color overlay of some degree of color to represent that delta frequency. So that's the basics, that's the fundamentals of Doppler ultrasound. So when we want to display that here, we want to look at that and say, actually put some math around this. We can say, okay, the Doppler, there's going to be some measurable distance, right? That's the delta F, right? This frequency received minus frequency transmitted. It's going to be dependent on the speed of sound that we interrogate, right? But also the velocity of the thing moving. So the equation, the Doppler equation that we'll come back to is kind of the basis for all this, is that delta F, it's at the bottom. Delta F equals the frequency received minus the frequency transmitted. That's what delta F means, right? Which is equal to 2 times the frequency transmitted, right? So the machine knows what frequency it sends out, times the velocity of that thing over the speed of sound in that tissue, right? And so we can see if we isolate this back out, delta F equals 2 times the frequency transmitted times the velocity over the speed of sound in tissue. And that kind of gives us the basis for our understanding of this Doppler principle, right? This is the math that the machine's going to use in the background. Now the question is, okay, so we have this in this scenario, right? We have this probe measuring blood flowing either away from it or towards it, right? And it's in perfectly parallel to the movement of the tissue. But as imaged here, I can't put a probe always perfectly parallel to that flow, right? I put the probe on the skin and not inside the blood vessel. And so I'm going to have to account for the fact that I'm looking at it from a different angle, right? And so when we look at it from a different angle, we're interpreting we may not get the most accurate assessment if we use this delta F equation that we were looking at. So we have to do a little bit of extra math, some trigonometry to account for that. So the parallel arrow in the middle of the blood vessel is the direction of flow, right? If I measure it using the long or that hypotenuse arrow, I'm not going to get the same exact measurement as that blood flow. And so we throw on a little bit of trigonometry, right? We can remember our right angle math, right? The A, B, C, and then the cosine, the sine, cosine, and tangent of different angles, right? That angle, and we can correct that angle, correct the B hypotenuse down to that C, the actual value that we see in the vessel. So to throw a little trigonometry into this equation, the frequency change, which is really what we want to know. We want to, what's this delta frequency, right? We know the frequency transmitted. Actually, we know the delta F. We can measure that. We measure what, we know the frequency transmitted. We know the frequency that received. We want to know the velocity that we're calculating for V, right? So we plug this in, right? We know the frequency we sent this out. We know the frequency we're receiving things back on the machine because the machine's listening for it. If we throw in that cosine theta after the V, right? So we have delta F equals 2 times the frequency transmitted times velocity times cosine of theta, right? We know B, we're measuring B, but we want to know C. So the math to make that happen is cosine, C over B, over the speed of sound in tissue, right? This is going to give us our final Doppler equation, right? Delta F equals 2 times the frequency transmitted times the velocity with the cosine, the cosine adjustment over the speed of sound in tissue, right? Which brings us to really the important point. And a lot of this is math. Probably a lot of you guys are glazing over this and being like, why are we talking about math in an ultrasound lecture? Well, number one, I'm a nerd and I like this, so sorry, you're gonna have to enjoy it with me. But number two, it's the fundamental basis for what's next and where it becomes really, really practical, right? And that is this angle of correction, right? So here we have the two kind of most extreme scenarios, right? The blood flow that's perfectly parallel to the flow of, or the ultrasound beam that's perfectly parallel to the blood flow, or the ultrasound beam that's perfectly perpendicular to the blood flow, right? And if we do the math, right? If we do the cosine of 0 degrees, that equals 1. So the most perfect cofactor for this V over C is 1, right? Because it doesn't affect the V at all. We know that V is kind of what we're calculating is what we're measuring. The opposite, where the cosine of theta is 0, right, where we're perfectly perpendicular, the cosine of 90 is 0, right? That 90 degrees is 0. And so if we throw that into the equation above, it makes V times 0, which means we can't figure this out, right? We can't measure a change in frequency. So that's the biggest extreme. So what this tells us is if you want the most accurate Doppler ultrasound measurements, you need to have your probe parallel to the movement that you're trying to interrogate, right? If you have your probe perfectly perpendicular to the movement that you're trying to interrogate, whatever's right underneath the probe, you're not going to see any change in frequency, right? So think about it this way. If you are observing this train as it goes by, and your only field of view is what's immediately in front of you, perpendicular to the train tracks, and the thing is, moving by, and you happen to snap a picture of it, you cannot tell whether it's moving forward or backwards, right? It's perfectly still. Whereas if you're if you're angled off to the left or angled off to the right, you might get a little bit of motion blur as this thing is, approaching you when you do your picture. Very crude analogy, but the point is at 90 degrees, you get basically 0 frequency change because the cosine of 90 is 0 and the math doesn't work. So I guess this brings up the question is then at what angle should I be measuring this, right? If I can't do 0, what angle should I measure it? And the answer is it's best to measure this under 60 degrees. And I don't have the graph in front of me here, but basically as you do this cosine adjustment, right, you can account for a little bit of, difference with this angle, but you add a little bit of potential error in the equation. And that error goes way up once you surpass about 60 degrees, right? So if you have your angle of interrogation less than 60 degrees, your math is reasonably accurate. But once you start going above 60 degrees and approaching 90 degrees, your ability to accurately measure that velocity goes way, way down. And so you need to readjust something to get your probe angle of inclination to be relatively parallel to the velocity or the movement of the tissue that you're studying, or the fluid that you're studying. So that's the basics, right? The basics of this Doppler equation. Now that I've thoroughly either put you to sleep or confused you, I want to go on to another principle that's really, really important, but a little bit mind-boggling all the same. And that's called the Nyquist limit, right? And this is where we get into some trouble accurately measuring the Doppler that we're looking at, right? So again, backing up, I want to go back to some, where we are, kind of our base understanding of ultrasound. Go like all the way back to the beginning, the basics, right? How does the probe work? And we'll build from there. So as you're holding this probe in your hand, right, it's emitting a sound wave, right? It's also listening for the returned echoes of that sound wave. Now, as you can imagine, how does a conversation go when you're around the dinner table? And again, we're on the topic of my family. So my kids and I and my wife, we sit around the table and we like to have a family conversation. And theoretically, it's this, Norman Rockwellian type event, right? Where we can all gather together as a family. In actual practice, it's just everybody talking all at the same time. And as you can imagine, that's really not conducive to a good conversation, right? A good conversation is a parlay back and forth where someone says something and then listens, and the other person says something and they listen. And so ultrasound in the best form is what we call pulse wave ultrasound, where it's a pulse of sound, and then it's going to pause and it's going to listen for that sound to return and then do something about that, right? And it's just a series of different pulses. If it's just constantly blasting, the noise just you kind of lose all that signal, right? So it's pulses of sound, and it listens for that return of that sound wave and then displays it, right? Now, how does it display it? Well, it displays it based on the amount of time that it takes to be emitted, and then when it comes back, and then it also displays on the intensity of the sound that's coming back. And so it knows, okay, I blasted out this sound at this intensity, I'm receiving it back X many milliseconds later at a slightly lower intensity. I will take that data and I will plot that on the screen. So that little that I heard back is going to be plotted, either higher or lower on the screen based on how long it takes to come back. And then it's a brighter pixel or a dimmer pixel based on how intense that is, right? And it's based on these assumptions that waves, are emitted, they bounce off something, and they return back. When we break this, obviously we get some artifacts, right? So if we break the if we have like a signal that bounces around, you can get like a mirror image artifact. And that's why we have that, around the diaphragm, you can see some like liver structures kind of up in the chest and things like that. And also, we are listening for the sounds that we hear back within that one pulse cycle. So think about it this way. Like if I send a pulse, and then it goes out and keeps going, and I send another pulse, the first one comes back and I display it, right? I don't necessarily know. It sounds like it, could have come back. The assumption is it came back within, the one pulse cycle, but this one actually took 2 pulse cycles. So it should be really, really deep, but it's going to display it higher up, right? Again, crude way of understanding this, but what we are saying is like when we break these assumptions that the sound goes out, it bounces off something, it comes back, we are left with some artifacts, right? And so this is where the Nyquist limit comes in. We're gonna throw in some artifacts essentially to this Doppler image that we're sampling here. So here we see an example of just we call aliasing, right? We see the color flow it's there, but there's all sorts of colors all over the place. It's this checkerboard of just explosion of color, and it really becomes very meaningless because we have this artifact. So let's dive in and talk a little bit about what this Nyquist limit is and how we improve this image, right? So basically we're sampling at a certain rate. We're sampling, at X many cycles per second of sound that we're sending out. So X many pulses per second. It's different from the frequency, right? The frequency is essentially the pitch of that sound wave that's being sent out. But there's a sampling rate of it sends it, X many, cycles per second, right? That's the pulse repetition frequency. And so essentially, you have to have a certain pulse repetition frequency to be able to sample movement. And the Nyquist limit basically means that, or the Nyquist limit is basically the rate that is required to measure moving tissue, right? And the Nyquist limit is equal to the pulse repetition divided by 2, right? Or said differently, the pulse repetition has to be more than twice as fast as the rate of the thing that you're measuring, right? The fluid that you're measuring. I want to prove this to you in graphical form, right? So let's talk about this as a sine wave, right? And we can look at this in different forms of objects that move. But in this context, I just want to use a sine wave because we can see this periodicity, this frequency, measured out over time. So our x-axis is our time, and we can see the undulation of the positive and negative deflections of the sine wave. So like I said, 1 cycle per second is represented here by those dashed lines. So I started at the top of the peak. You can start wherever you want, but this one's at the top of the peak. And to go 1 cycle, you go all the way down, and you go all the way back up, and then you're starting over again at the top of this peak. So if the goal of this little mind experiment here is to reproduce the sine wave, or I should say, the goal of this mind experience is to reproduce this sine wave above on the graph below simply by finding a rate of capture where as we travel through that sine wave, we can then reproduce it using these red dots below, right? I don't know if that makes sense, but that's kind of what we're doing. So if we set the rate of our capture equal to the frequency of this wave, right? So when it gets to the top, it captures and places a dot on our graph below. What we're going to be left with is a whole bunch of dots in a line, right? And so we cannot reproduce this sine wave because if you were to connect all these dots, essentially all we would be doing is drawing a straight line from left to right. So we're going to have to increase the rate at which we sample the above sine wave as we're kind of going through this wave, right? So let's go to, in the next example, a 2x frequency, right? So 2x sampling rate. So if we sample twice the frequency, we're going to sample 1 at the top, right? And 1 at the bottom, and then 1 at the top and 1 at the bottom. And if you look at it, we plot those dots on the graph below, we can start getting close to reproducing what this sine wave looks like, right? We have 1 at the top, 1 at the bottom. If we kind of draw lines from dot to dot and then maybe round them out a little bit, we can really approximate that sine wave, right? So you're like, that's great. One problem, right? What if I shift the phase by just a fraction of a period, right? So we're going to shift it over just a little bit, right? Same frequency, it's 2 times the frequency, but we're shifted over just a touch. Now all of a sudden, all those dots fall to the baseline, right? Because that's where the sine wave crosses where we sample it is where it's crossing the baseline, and we're back to drawing a straight line. So again, 2 times the frequency, the sample rate of 2 times the frequency is not sufficient to accurately reproduce this sine wave, right? And so to accurately reproduce it, we actually have to increase that sample rate to greater than 2 times the frequency. So let's double it again, right? This is 4 times frequency. And now all of a sudden we have a dot at the top, at the baseline, at the bottom, back at the baseline, at the top, and we can go back and forth. And it doesn't matter where we are in that cycle, right? We can shift the phase wherever we want. We're going to have dots on this graph such that we can reproduce this actual wave in the graph below, right? And we can go to, 8 times frequency, we can go to whatever multiple, and we're going to have just multiple dots along this line and be able to accurately reproduce it. So hopefully that makes a little bit of sense to say why we need greater than the sampling rate, the pulse repetition frequency, to be greater than 2 times the frequency or the velocity of the thing that we're measuring. Now, getting back to this principle of aliasing, what happens if our pulse repetition frequency is not high enough, right? We showed where it could just show a flat line. What if we slowed it down to below 1 times the frequency, right? So here's an example here where we sample at something well less than 1x of the frequency. And now all of a sudden we get dots that cross the baseline or that are reproduced on this sine wave that kind of create a wave of its own. So if you imagine this in your mind's eye, connect the dots, you get this alternate wave, right? This really low frequency wave that doesn't do anything to reproduce what the actual wave is in reality, right? And so this is the principle, at least the fundamentals of the principle that we call aliasing, where your sample rate is set inappropriately. It's set too low, and you cannot accurately resolve the frequency that you're trying to detect, right? It's going to display it as something different. So you're great. This wonderful works in theory, but where do we actually see this in practice? Like, how does this affect me at all, or is this just a long-winded way of showing some pretty pictures? So where we see this in practice, I'll show you one place, and then we'll take it to ultrasound. So part of what we do here at MetroHealth is we have a flight service, right? So this is an example of our helicopter service. They were doing a check ride, right? And so I was out videoing their check ride. And if we video the check ride at 240 frames per second, the image on the left, right? And at 30 frames per second, notice the direction of spin of the rotor blades, right? So in the 240 frames a second, it's going a counterclockwise direction. And in the 30 frames a second, it's going in a clockwise direction. Now, it's the same helicopter. They're flying around doing the same thing. It's at two different sampling rates on the camera. And so what we're seeing is, based on this aliasing principle, because of the aliasing principle, based on the frame rate that we have in our camera, we can adjust the direction that the rotor blades are going. The rotor blades aren't changing direction. It's just the sampling rate causing us to see it artificially is going the opposite direction. So let's apply this to ultrasound. How does this get seen with ultrasound? So we have two different forms of ultrasound. We'll get into this here in just a minute, but we have color Doppler and we have spectral Doppler, right? Color Doppler is the color overlay. Spectral Doppler is a graphical overlay. When we have aliasing, we're going to have a violation of the standards of this ultrasound. So color Doppler, it's red and yellow going toward the probe, and it's blue going away from the probe. Spectral Doppler, anything above the baseline is going toward the probe. Anything below the probe or below the baseline is going away from the probe. When we start aliasing, we start getting a variegation of that color, right? So either we don't have the normal laminar type flow like we see at the end of this clip here on the right. We have just that speckling of just a random assortment of colors that really doesn't tell us whether things are going uniformly in one direction or the other, right? So you get this speckling artifact. In the left-hand image, right, we see this spectral Doppler, and I tried to color code this in a gradient here. It's going from red all the way down to yellow. But what we see is the flow. So this is a regurgitant jet, right? And the scale is set inappropriately, so we're getting a lot of aliasing artifact. But we see the signals emanating from the baseline going down, right? That's the appropriate direction, things going away from the probe. But because it's aliasing, it wraps it around to the top and continues all the signal that we see going from the top down towards the baseline, right? So you can imagine, the Doppler packet continue on. If you were to take the stuff from the top and move it to the bottom, that would be the totality of the waveform. But because our sampling rate is inappropriate for the velocity we're measuring, it's going to wrap around to the top and show frequencies that are in the wrong place, going the direction that we're trying to show. So that's what aliasing looks like with ultrasound, right? It's going to introduce a lot of error in our measurements when we're doing Doppler ultrasound to really accurately measure and quantify maybe flow or at least qualitatively show the direction of flow, right? So the principle here that we can take away is, for fast flow, we need a high pulse repetition frequency, right? We need to turn that rate up, and we can adjust that with the scale adjustments on our machine. And for slow flow, you need a low pulse repetition frequency. And if you don't do this correctly, right, if you have a low pulse repetition frequency and you're measuring something that moves fast, you're going to have the machine's not going to be able to resolve that. You're going to get aliasing, and you're going to get a whole bunch of artifact that tells you really nothing about the flow that you're looking at. So you have to adjust it for the flow that you're expecting. So what if I'm looking at fast flow? Turn that scale up, right? And see what you can get. However, there's a limit to what you can do, right? So using the typical pulse wave Doppler, and we'll get into the different types of Doppler here in just a sec, there's a limit of about 1.5 meters per second that you can accurately resolve. But sometimes there's scenarios where that flow is greater than that 1.5 meters per second ability to resolve that. And so there is a special form of Doppler called continuous wave Doppler that is less sensitive to the velocity, the ultimate velocity, that we can actually utilize. And what it does is it basically dedicates some of the crystals to constantly talking and some of the crystals to constantly listening in that ultrasound head. And so it'll give you a velocity, but it won't give you a precise location for where that velocity is taking place. We don't have the location precision along that line as much as we would with a pulse wave, but we can tell you that it is a higher velocity kind of in somewhere along that line. So that is the whole idea of aliasing and a little bit of a ways to get around it. Let's back up a little bit and let's talk a little bit about these color versus spectral Dopplers, and then we'll see kind of how we can customize and adjust those as we go through our ultrasound image, right? So color Doppler is simply a graphical color display that's superimposed on top of a 2D image resulting from frequency changes that are caused by movements in the fluid or tissue. So long-winded way of saying, if we measure something where the tissue is moving, i.e. the fluid's moving, right, we can detect that change in frequency. Remember what we talked about way at the beginning, that delta F is equal to 2 times the frequency transmitted times the velocity over the speed of sound in tissue. That delta F that we measure, right, we can display that on top of the 2D image that we're looking at. And the greater degree to which that frequency is changed, the larger that delta F is, we can display that as a different color, right? And so customarily, we display orange and yellow tones as blood moving toward the transducer, right? And the blue tones is blood moving away from the transducer. Use the mnemonic BART, right? Blue away, red towards. So anything that's displayed in red is frequency shifts that are towards the transducer. Anything that's in blue is frequency shifts that are away from the transducer. And then the degree to which that frequency is changed, right? That velocity change is displayed in various different intensities. So the highest velocity is in the yellow, the high toward the transducer. The highest velocity away from the transducer is in that kind of the cyanish whitish color. And then things that are less are displayed in darkening colors of that red and orange, or in the blue, if that makes sense, as we're kind of looking at this image. And so here's a practical example, right? This is an image of a tricuspid regurgitant jet. And we can see this blue plume that's emanating from that tricuspid valve. And as we look at the orientation of the heart, the blood's flowing kind of to the left and downward deep into the screen, which means it's flowing away from the transducer. So it's going to have a relative blue color. If we were to somehow change the angle of interrogation so that that plume was going toward the transducer, we could turn it into an orangish yellow plume, but since it's going away, it's going to be in this blue. And so this brings up the idea of, we like to think about arterial stuff as red, we like to think of venous stuff as blue because that's the way all the colors are drawn, or the pictures are drawn. But when it comes to Doppler ultrasound, red and blue do not necessarily correspond with arterial versus venous. They correspond with the direction of flow. And so if you orient your transducer such that the arterial flow is going away from the transducer, you can make it show up in blue. You can also reorient your transducer so it can show up in red, but it denotes the direction of flow, as we see in this image with the tricuspid regurgitant jet. Here's another example where we can see some aliasing that we can, in this image where we've pretty much set the pulse repetition frequency so low that we cannot accurately resolve. And so here's what we see in here is like this mixed bag of like red versus blue, kind of all in the same period. So we have to adjust that pulse repetition frequency of the scale on the right to reflect the flow that we're looking at. And that's the second component of this color Doppler, is not only do we need to get the directionality right, but we can also adjust that scale to have greater numbers of velocities that it can resolve. So let's move on to spectral Doppler, right? So this is, by definition, a quantitative graphical display of fluid or tissue in the direction of the frequency changes that's caused by the fluid, caused by that fluid or tissue. So as we measure the blood flow through a thing, right, through a valve, through a vascular system, there's going to be a directionality to it. There's going to be a frequency change to it. And if we put our spectral Doppler on, we can actually plot that on a graph, which means we can actually put numbers to that. We can put velocities to that. We can measure the slope of the acceleration. We can measure the slope of the deceleration. We can see a lot more characteristics of that blood flow that we wouldn't ordinarily be able to see with just a color display, right? And so in essence, what we're doing is we're saying by convention, anything that's above this baseline, right, above the x-axis, like the x-axis represents time, anything above that is flow moving toward the transducer. Anything that's below that is blood that's moving away from the transducer, right? And then the frequency, like the velocity is measured is part of the amplitude of this wave that's being displayed here. So the higher the velocity, the higher up on the graph, the higher away from the baseline, the lower the velocity, the closer to the baseline. And then the intensity is the number of signals that are being detected, right? And so here we can see some decently laminar flow where we have most of the signals that happen as you go over time happen within a very narrow range of velocities for a given period of time. So you can see that column of blood accelerating, right? Peaking and then decelerating all about the same time with that little black spot in between each peak there is the spectral window. So you can actually get a really good understanding of what's the dynamics of what's happening with that column of blood as it's moving, as it's accelerating, as it's peaking, as it's decelerating, how much velocity that thing is attaining at each different period of time, right? And so that's the benefit and the advantage of spectral Doppler. Now there's two forms of spectral Doppler that we talked about. The first one is this pulsed wave Doppler, and the second one, like we said, is the continuous wave Doppler. And so basically what pulse wave Doppler is kind of what its name implies. It sends pulses of sound, right? And then it listens back for that sound to return, and it listens for the frequencies at a certain location where you set your gate. So if you notice in the top part of the image, there's that dotted line that represents the Doppler line, and there's two hash marks, and that's the gate, right? So what we're telling the machine is this is the depth that we're concerned about. So when you hear stuff coming back at a certain expected time, right? So it takes a certain amount of time to go from the top of this display down to that gate and back, right? The machine can figure that one out based on the depth and things like that. It says listen in that little range of space for the frequency shifts that are coming back. I want you to focus in just on that and display those, right? And we display that on the bottom on this graph down here. And so what it gives us is a very accurate representation of what's happening at a very precise location, right? That's the benefit of the pulse wave Doppler. But like I said earlier, it's limited to the amount of time or the velocity that it can resolve. Because if you think about it, you have to send pulses at a certain rate, right? We talked about that at the very beginning of the right after as we were talking about the Nyquist limit, right? There's a certain frequency that you have to send those pulses out at to be able to accurately resolve the velocity of the blood that you're interrogating in that area, right? You got to be able to sample it fast enough. But as the velocity increases, eventually you're going to outstrip your machine's ability to send those pulses out fast enough just because of the physical limitations of the speed of sound in that tissue. And as you can imagine, right, if you're interrogating something very superficially, you can maybe get your PRF up a lot faster. But if you have to interrogate something way, way, way down in the bottom of the screen, it's going to take a lot more time for that sound to go all the way down there and back up. So you're limited even there with how fast you can get that pulse repetition frequency up, right? How fast you can make that happen. And so it gives you some velocity limits as you're interrogating this particular area, of the vascular flows, right? And so that limit is about 1.5 meters per second. So here's a little arrow shows you where that gate is if you haven't found that already. So like I said, sometimes, especially when you have like regurgitant jets or stenotic jets, the velocity of blood flow through that area exceeds the 1.5 meters per second. And so the way to get around that is with a second form of spectral Doppler, and that is called continuous wave Doppler. And like I mentioned earlier, it is essentially portion of the ultrasound probe is transmitting simultaneously while a portion of the probe is listening, right? So it dedicates a certain portion to sending and listening. And so it just sends out the sound and it receives it back. And so it can hear those frequency changes. It says, I sent out the sound at this frequency. I sent it, I'm receiving it back at this frequency. But I also cannot discern, where this is happening, right? Because I'm just listening to all the frequency shifts that are happening over a course of time. And so it's going to display them all, right? But it's not going to be able to tell you at this particular precise location, along this line is where this one's happening. So you're going to have to use your clinical understanding of what's going on with the patient, where, where the stenotic or regurgitant jet is, and you say, okay, the peak velocity is probably going to happen in this area, so that's probably what's represented here. But again, I can't mathematically show you this is what's, the precise location of where this is going on. So that's essentially continuous wave Doppler. There's the Doppler line. That little diamond does not represent kind of that pulse wave gate, like we talked about earlier. So the final part of today's talk is, okay, with all this background information, with all this theoretic information, how do we punch buttons on this machine to make this work, right? How do we activate this? How do we manipulate this to get the information that we're looking for? And so I want to show you a couple different machine controls as we go, as we wrap things up today. So then you can then take this out, manipulate the images where you're looking for Doppler signal on your ultrasound images at the bedside. So very fundamentally, very basically, to activate these settings, there's buttons on the machine, right? The CW button for continuous wave, PW for pulse wave, and just the color button for color Doppler. So most machines, you're scanning in 2D mode, there's usually a button that you can push to activate the Doppler settings that you're looking at. And oftentimes, like for pulse wave, it'll give you the opportunity to adjust where you want your Doppler line and your pulse gate, and then you can hit it again, and that will activate the actual the spectral display at the bottom that we see, the graphical display, right? The next thing that we need to work on, or we need to adjust, is that angle of interrogation. So we talked about very, very early in the talk how things that are or blood flow that is parallel, or let me rephrase it, the ultrasound beam that's parallel to the direction of blood flow is going to be the most accurate, because the cosine of 0 degrees equals 1, right? The blood flow that is perpendicular to, or the ultrasound beam that's perpendicular to blood flow is going to be the least accurate. It's actually going to not be able to resolve it because the cosine of 90 degrees is 0. And so we want to get our angle of interpretation or interrogation to be less than 60 degrees off of the direction of blood flow that we're actually looking at. And so we can do this in a couple different ways, right? The most easy way is just adjust the angle of or the transducer angle. So here on the left, we see, let me start on the right. Here on the right, we see just a square-on view of the carotid artery, right? We can see as we're looking extremely perpendicular, you kind of get this mixed red and blue flow because you can't really tell, what the probe doesn't, it's 90 degrees, right? It can't really tell what direction things are going. It just knows that there's some degree of flow. And see some forward, some backward. You don't, like, which direction is this thing going? If we simply just do a little heel toe, right, we kind of adjust the angle of the carotid artery relative to the transducer, we can all of a sudden see that it's blood flowing toward the transducer, flowing up that carotid artery. So the carotid bulb is to the left in both images, right? So a simple transducer angle manipulation will make this become a lot more accurate in terms of its ability to resolve the direction of flow, right? Now, what if you can't angle your transducer? Well, you're in luck. We have another option, and that's adjusting the box angle. So because this is all electronic control of these ultrasound probes, right, we can fire the different crystals at different times, right? We can fire left to right, we can fire right to left, we can fire center to out to center. But essentially what it does is we can adjust the angle that this ultrasound beam is emitted from the ultrasound transducer electronically. It's called electronic beam steering. And so we can there's a button, we can adjust the direction of this box, right? We see on the right-hand side, it's pretty much a square box. On the left-hand side, it is a box that's skewed to the left, right? So we can adjust this box angle to simulate changing the probe orientation relative to this vessel. And that will allow us to then be able to see, directionality. And if we were to move the box angle skewed toward the right, we could change that flow to a blue flow, essentially, because the blood flow is going away from this box, right? So that's a couple of different ways. If you want to look at it on the screen, here's an example. There's the angle button that you can use to adjust this. And this is Also equally applicable, and what we're seeing here on the right-hand side is when we're adjusting the pulse wave gate, right? So you can do the same thing with pulse wave Doppler, where you have the angle that you're adjusting the Doppler, but also you can tell the machine which direction the blood flow is going. That's the second arrow there inside the gate. And so you can have it electronically steer that angle, that probe, or that ultrasound beam, but you can also electronically tell it what that cosine degree is by saying, here's the direction of flow that you should expect, and it can help you do the math based on adjusting that line and that gate. So that's one of the big adjustments that we can do. The second one is the pulse repetition frequency, right? And so we talked about this with the aliasing, right? If we have our pulse repetition frequency set too low for the velocity that we're interrogating, we're going to get aliasing. So a low PRF works great for venous flow, right? Things don't move very fast. We can resolve that very, very well. But as we transition to arterial flow, again, this is the carotid artery, and we have that scale set way too low. And so you can see the numbers adjusting on the right-hand side of the screen. If we have that scale set way too low, all of a sudden we're going to start getting aliasing. And to remove that aliasing, we start increasing that pulse repetition frequency. We just hit that scale button, bring that back up, and it's going to start giving us that nice, smooth, monocolored flow. So that's the second adjustment that we can do to make our images better. The third one is color gain, right? So if we know what gain is based on our 2D image, it's basically the sensitivity of that probe listening for signals back. It's like, I always use the example of my grandparents and their hearing aids, right? It doesn't make me talk louder. I mean, we did talk louder when my grandpa couldn't hear very well, but he has his hearing aid and he can turn that up and adjust the sensitivity of that microphone in the speaker that's in his hearing aid so he can hear the sounds better, right? And so on ultrasound, as we turn that gain up, things get brighter, right? We can see things better. It may get noisier because now we're listening to a whole bunch of sounds. And the same thing also applies in the Doppler space, right? If we turn the color gain up, now we're listening, we're tuning out some of the subtler frequency changes that may not be reflected from the flow that we're actually trying to interrogate when we have it turned down low. And when we turn that up, now we're becoming more and more sensitive to all the little subtle frequency changes that the machine is detecting and is trying to filter out for us, right? In the third or fourth, I lost count now, thing that we can adjust, particularly when we go to the spectral side of things, is our baseline. So not only can we adjust our pulse repetition frequency, or that scale, to give us a velocity range, but we can also adjust where on that velocity spectrum we're looking at. So we say, hey, you know what? I'm only interested in blood flow that's going toward the transducer, right? Now I have a certain range of velocities that I can actually resolve, but I don't care about the stuff going away, right? So I'm going to adjust that baseline down low so that I'm only looking at things from 0 centimeters per second to positive, in this upper right example, 120 centimeters per second. Whereas if I know that I want to go below the baseline, you can look at 0 down to a negative deflection of 80 or 100 centimeters per second. And so if you're having a hard time resolving the frequency without aliasing, and you can't adjust your pulse repetition frequency enough to be able to narrow that down into a scale that you can resolve, try adjusting your baseline, because that could then show you a broader spectrum in the area that you're looking at, as opposed to looking at things both above and below the baseline. So those are a handful of different adjustments to help improve the Doppler image. All right, so I hope that was helpful for you as you think through Doppler ultrasound. Maybe you have some experience with using it, but don't know some of the details about why it works, or you're brand new to all this and you want to learn more about how Doppler ultrasound works so you can be better at using it at the bedside. Hopefully this was helpful and instrumental, and now you can go out and apply it and learn how to use this or do this more on your patients as you're scanning hearts and blood vessels and all sorts of good stuff. Now I have a special announcement here, and that's really about what's going to happen here over the course of the next couple months. Now don't worry, we're still doing this. We're still keeping this thing alive, but there's going to be some changes that you're going to notice, at least for a couple months. Now that's because my wife and I are welcoming our 6th child to the world. Now, at the time of recording this, we're about 2 weeks out. By the time you actually watch this, probably still got about a week to go unless things go early. But that being said, I'm going to be taking some time off between now and the end of the year to help my wife out as she's recovering, to spend time with my family, to acclimate to having a new little child in our home. And so I won't be here, but I've actually prepped some material so that we can continue this on while I'm on leave. And so you're not going to want to miss it. We're going to have some really great talks coming up, some interviews that I've pre-recorded, some demonstrations about doing ultrasound. Stay tuned to this channel, hit that subscribe button, hit that notification bell so that you can be notified when these upcoming videos come out. We definitely appreciate you being part of this ultrasound education movement that we're doing here, and we look forward to bringing more of it to you in the future. So thanks for watching. I'll see you guys in the new year when I get back. Have a great week. Bye.